All right, so good evening, everyone. My name is Emily Horvat, and on behalf of Respiplus, it's my pleasure to welcome you to today's webinar, another presentation of the Expand Courses online training platform. So today's webinar, The Successful Chronic Cough Journey and MDT Approach, will be presented by Dr. Alan Kaplan, Dr. Imran Satya, and Sara McRae. So we're very pleased to be able to offer this continuing education opportunity, which is made possible by a sponsorship from Merck Canada. Just a couple of technical aspects before starting. If you're connecting to the webinar by phone, please note that your line will be muted during the session. If you have any questions, we ask that you use the Q&A section. You should find that button towards the bottom of your screen. For any technical questions, if you're having issues, then you can use the chat, but the Q&A section for questions, please. And we'll do our best to answer those either throughout or at the end. So note that we're hosting the same webinar next week as well. So a recording of one of the sessions will be made available for viewing on the expandcourses.com website. You'll get an email about this tomorrow afternoon, probably. And this webinar is also accredited by the College of Family Physicians of Canada. So a certificate will be emailed to you tomorrow as well. A quick introduction to our speakers. We have Dr. Alan Kaplan, a family physician working in the York Region, Ontario, Canada, and is the chairperson of the Family Physician Airways Group of Canada, the past chairperson of the respiratory section of the College of Family Physicians of Canada, and Senate member of the International Primary Care Respiratory Group. He co-chaired the Community Standards of COPD Program for Health Quality Ontario. And in addition, he provides his expertise to a number of medical journals across the world. Dr. Imran Satya is an international renowned expert in the field of chronic cough. He's currently an assistant professor at McMaster University for the Department of Medicine, Division of Respirology. He completed his medical degree at the University of Cambridge in the United Kingdom and also completed a PhD at the University of Manchester. He was a co-author on the most recent ERS chronic cough guidelines and is a scientific advisor for pharmaceutical companies developing new chronic cough therapies. He has been an invited speaker at national and international medical conferences and has authored numerous publications on the mechanisms and treatment of cough. So Sara McRae did her Bachelor of Arts in Psychology at Western University and then completed her RRT at the Michener Institute for Applied Health Sciences. She's been an RRT since 1996, worked at the Ross Memorial Hospital for 2 years, and for the past 24 years has been with Medigas. Sara also completed her COPD and asthma educator courses and was among the first group that wrote and passed the CRE exam. So with that, I'd like to welcome Dr. Kaplan, Dr. Satya, and Sara and invite them to begin their presentation. So over to you, Alan.
Emily, thank you very much. It's wonderful to actually be here with all of you tonight and with my esteemed colleague. It's going to be fantastic. So just in terms, you've seen our individual conflicts overall. We're getting some support from Respiplus. This is unrestricted educational grants, so we didn't have to answer to anyone except the three of ourselves. And of course, Emily, we always have to answer to Emily. And we have lots of product. We deal with a lot of companies with a lot of products, but that really isn't the point of today, because really what we want to talk about is talking about the entity of chronic cough. And we want you to understand that this is a condition that actually is a real condition rather than just something left over from a bunch of other conditions. So we're going to explain that. We're going to talk about medications. We'll talk about drug classes for the most part, unless there's only one drug in the class, then we may be talking about it that way. So really what we want to talk about is and this is really a patient-centered program here tonight. We really want to understand this from the point of view of the patient, because my experience, and Imran will share with you as well, that by the time someone actually has a solution, if they have a solution for chronic cough, it takes many, many years and lots of tests and lots of doctors. It's frustrating and they suffer for a long time. But I think we do have an approach to chronic cough. We have a way to look at the way that's going to be organized, and we're going to share that with you. And then we're going to talk a little bit about how we, both primary and secondary care, can work together, because we really have to do that to get things done quickly and efficiently as possible for our patients who suffer. Now, Imran and Respiplus and all of us were involved in creating this Canadian Chronic Cough Initiative. It was a report that was created by a lot of people that included both clinicians, academics, as well as patients, really to talk about what this can be done. This is available on the Respiplus Cough website. It's also available through the Family Physician Airways Group of Canada website. We've got a link there as well. So we talk about patients, we talk about experience, and we have a whole bunch of things in this that includes a lot of education for us as clinicians, indicating the etiology, the pathophysiology, the diagnosis, and how we make our steps in our way through chronic cough. Then to manage the entity of chronic cough, we're going to get into that a little bit more. And then we're going to talk about some models of care and how we can do this a bit better in this program. So, Imran, I don't know if you have any other comments you want to make about this program.
Yeah, thanks, Alan. So one of the things I think that the viewers might benefit from when looking at this report, as far as I'm aware, I think this is the only ever report which has been conducted, not just in Canada, in the world, which has taken stakeholders from patients, RTs, respiratory physicians, allergists, immunologists. So it brings together a wide variety of stakeholders to really give their opinions and their thoughts and their real life experiences of dealing with chronic cough. And there's various themes that emerge out of this, and Sarah will talk more about this. But from the patient's perspective, delays in diagnosis and people not taking them seriously, it was a major concern. From the physician perspective, particularly primary care, there's a kind of a lack of understanding of who to refer, when to refer, what trials of treatment to do. And from a specialist perspective, even from our perspective, often when they come to us, we only see the most severe of the severe. Often patients are extremely frustrated by the time they come to see us. So a lot of this report talks about some of these important challenges, and I hope that some of you will have time to go on the website and have a read of this. And I think it's a really unique report, which is not published anywhere in the world that I know of.
And rather than it being just an article about cough, which we've all been involved with, this is actually from the patient point of view as well. So it really talks about this in lay methods as well. So it's actually appropriate for your chronic cough patients as well. So there's a lot of firsthand experiences here. You can see a lot of patient experience. I'm not going to go reading through all this because I have better than on paper. I got a real one. I got Sara here to talk about it from her point of view, and we're going to do that. But a lot of really just quotes from people who went through the process. So I think it's really quite an exciting piece of work. So Sara, over to you now, because I think I'm really excited to hear this from Sara's point of view. She's lived this. We as clinicians have all kinds of patients, and we talk about them in the abstract. But we actually have Sara, who has enough respiratory knowledge to make this both educational but also personal. So Sara, if you want to unmute yourself, and it's up to you.
All right, thank you very much, and welcome everyone. So I'm going to give you a brief synopsis before I start, and then we'll go through the slides if that's okay. Essentially what happened is, as a very young girl, I was repeatedly having a breathing issue of some sort. So whether it was a bronchitis or it was a whooping cough or chest infection of some sort, I always had one. Back then, because I am getting older, back then there weren't nebulizers in the home as much, so I would have to go repeatedly up to the local hospital for nebulized treatments and chest physio. At some point throughout that young time frame, they diagnosed me with asthma. And just to be clear, there were no actual formal testing done at that point. So I spent about 30 years being treated with corticosteroids and salbutamol. So having said that, and before I give you all the rest of my information, I'm going to start by going through the slides here. So I do live with my husband. We've been here for about 23 years. I am currently taking those medications, as you can see, the Detector, because as you'll hear down the road, they thought I might have GERD, so we tried that. Hydrochlorothiazide, because I have a bit of a blood pressure issue, but nothing major. Levothyroxine, pretty basic with everybody, and Lyrica to help stop the cough when I sleep. We'll come back to that, I'm sure. So as far as what happens is I've been presenting with some form of chronic chest infection, acute chest infections for about the last 30 years. And in the last 15, the cough has progressively gotten worse. So it got severe enough that one day, one of the respirologists I was working with in a spirometry clinic heard it. And after I finished coming out of the bathroom with reddened face and crying and everything else, he said, "What is that?" And I said, "That's just me. That's my chronic cough. I've had it for years, blah, 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 blah." And he decided at that point, no, that's not normal. Let's do formal spirometry. We did that. We did methacholine. And that's where we started from. And lo and behold, I don't have asthma. So I have the dry cough, tends to start in my throat, continues to the point that sometimes it makes me stop in the middle of presentations. And I should put that out there tonight. If I do, I've already asked Dr. Kaplan to take over and read through these for me. But hopefully that doesn't happen. Changes in temperatures is one of my triggers. Strong smells, specific smells. Vanilla, the smell of vanilla makes me go into a chronic cough. And it's a pretty common smell. And stress also can make me get worse. Those are probably the big ones. But as far as other complications, as you'll hear as I go through these slides, I don't have any. So if we can go to the next slide there. So,
Sara, can I ask you a quick question about
absolutely, sure,
that you get in your throat? Would you describe it as an itch, a tickle, or something stuck which you feel as if you need to cough out? You have to get rid of it. How do you describe that feeling?
So it usually starts as a bit of a tickle, and I can feel it coming on. Then it proceeds to get to the point where it's like it feels like there's something there, and I will like do the until it comes up there. And when I say comes up, it's usually mucus, clear, sticky, white mucus. Yeah. Does that answer the question?
Yeah. And interesting, in between these acute infections that you used to have many years ago, would you say in between those episodes you had no cough whatsoever? Or did you
maybe when I was maybe when I was as a young child, but in the last 15 years, it's pretty much daily that I have a chronic cough, attack or fit.
Independent of these infections that you used to get.
Absolutely.
Okay.
Absolutely.
Thank you.
So again, I was diagnosed as having asthma when I was younger. Truly wasn't asthma, we found out later. But the doctor then sent me further to do allergy testing, immunotherapy testing. As it turns out, my allergies are cat dander and elm tree pollen. We don't have any elm trees around us, so I'm not thinking that's the issue for me. I don't have heartburn, indigestion. We did ENT, there's no polyps, it's clear. As I said, my occupation has been a respiratory therapist. I've worked in home care for almost 25 years, I guess. And non-smoker, I have never smoked. I don't have you can read that. No fevers. And as far as weight loss, I don't have any major weight loss going on. Our house is completely carpet free. We have hardwood or ceramic tile, so it's not something from that. We've even changed our heating. We have no, our heating is a heat and moisture or a heat exchange. So there's no dry heat, there's no wood heat, nothing like that that's causing the issue.
So I'll jump in here, Sara, for a second. I want to point out some of those pertinent negatives that are there. There's no hemoptysis, there's no systemic symptoms. I'm going to come back to the concept of red flags a little bit later, but we have issues of people who have a cough, which can be a nuisance. So we have people which have a cough that's actually a harbinger of a very severe illness. So as we're thinking through Sara's case, as we're leading through it, I recognize our worry changes from one thing to another, to making sure that we're not solving something that's an urgent problem versus something that's, of course,
absolutely. So if we can go to the next slide. Diagnostics. At this point, we decided we've done this spirometry, we've done the methacholine, we've done the allergies, we did immunoglobulin testing. My respirologist sent me to do a CT scan. At that point, I think he was a little worried it was bronchiectasis. My CT scan was clear. I did have some chest or heart sound issues, and I think you're going to do the echo stuff a little bit later, Dr. Kaplan. And so it wasn't anything that was really worrisome that would be causing the cough. So that's where we started there. And then if you go to the next.
Clubbing is something to think about, guys. We don't always look at fingers, but clubbing is a significant issue for people with respiratory illness. You have to think about interstitial lung disease, a number of different things. So it's always worthwhile to have a look at those fingers to make sure there's no clubbing.
Absolutely. Fingers are good.
So with that, as you've met Sara's case here, sorry, Sara, you can go ahead and do it if you want. What do you want to do next, right, as a clinician? We've done some spirometry already. Don't know if Sara said it's either reversibility or not, but let's assume there was no reversibility, so we've ruled out asthma. We've done a methacholine already. Pheno is something that you're going to hear more and more about in the next little while. It's a small little device that you blow into, and it gives you a measurement of fractionated cell nitric oxide, which is a surrogate measurement of eosinophilic inflammation in the lung. There's some rules about it, but it's actually a very simple test. It's just not covered in very many places. So most of us have not heard of that. I've actually just got a machine for my office. What about just doing a blood count? Is there anything we're going to learn from a blood count? And of course, would you like to see a chest X-ray? So we're not going to sort of make you go through this and pick choices. That would probably take too long. But we're going to need to think about what things you might want to do in addition to this case. So, Sarah had a chest.
Yep. Sorry. Go ahead.
Well, this is the clinical part. So again, message. Someone with a chronic cough needs a chest X-ray. Don't skip that step. Don't skip that step ever. It'll come back and bite you. I was just at a program created by some of my colleagues in the UK where they talked about non-smokers with lung cancer, and it happens. So we have to be concerned. You don't want to miss that. You feel terrible if you didn't do that X-ray and miss a big proximal lung cancer because you say, well, she's too young, it couldn't possibly be her, but we see people in their 30s having lung cancer. So please don't miss that. Of course, there's all kinds of other things you can see on X-ray as well. So that chest X-ray is important. Pheno is useful because it'll tell you about eosinophilic inflammation in the lung. But again, we sort of ruled out asthma based on her spirometry. But of course, the spirometry, if it was done a day she'd just taken her medication, may not be helpful. So that may also be an issue. CBC, you're going to hear more and more about blood eosinophils over the next little while. Blood eosinophils can give you a good hint about eosinophilic airway disease. And certainly in asthmatics is a good marker of risk of exacerbations. And COPD is a good marker of the need of inhaled steroids. So that can sometimes be helpful. And that blood eosinophil count is down at the bottom of your CBC count. You look it down there, it'll say 0.3. And that would be 300 eosinophils, which is considered significant. And of course, the chest X-ray is still first, but at some point we need to do spirometry as well. So Sarah notably did not say she'd had a chest X-ray in that story. So back to you, Sarah.
Absolutely. So I didn't have a chest X-ray done. We went straight to the CT scan. Having said that, with the spirometry, as you said, mine came back normal. There was very limited improvement. And I do find sometimes if I'm in one of my coughing attacks, the Ventolin helps a little bit. So I always do have one on hand, just in case, but typically not that big a deal. My methacholine, like we said, was normal. We did do a lot of blood work. We did all the immunoglobulins, and I do have an IgG1 deficiency, very mild deficiency. But other than that, we didn't have a lot. So if we go
Imran, do you want to comment here?
Yeah, just one of the comments before that, you know, the issue of whether or not somebody should do a CT scan, that and a Pheno, that came up in the last ERS guidelines that I was a part of. And what the evidence suggests that in people who have an initial chest rate which is completely normal, that there's no evidence that they would benefit from a CT scan. If there's some abnormalities or there's evidence of bronchiectasis or you're uncertain, only then is it useful for microbiological analysis or areas where you might think there's bronchitis. For the Pheno, unfortunately, the level of evidence, there's not too many studies, unfortunately, to assess this. But what the evidence suggests that if you have a Pheno of 45 or 50 or more, then that could be a sign that you have asthma or eosinophilic bronchitis. But as Alan's already mentioned, Pheno is not easily available in Canada, and you have to pay for it, whereas it is in the UK and other European countries. It's available. So those were the 2 points I wanted to mention for people attending and listening.
So again, Sarah had mentioned they did a CT scan to rule out bronchiectasis, which is a really good thought for someone who has recurrent productive sputum and infections. That's a really good thought to think about that. Of course, if you've got bronchiectasis, then you have to explain why you have bronchiectasis. Immunoglobulin is very important. She had recurrent chest infections. If you don't think about the fact that there may be an immunologic deficiency causing those infections, you'll never make the diagnosis. And of course, an early diagnosis, obviously hers is mild, but a more significant deficiency would potentially could need immunoglobulin replacement, which then can make a huge difference for the rest of her life. So each one of these steps are really quite important. 0% eosinophils is interesting because does that mean that it's not? Well, of course, could also depend on treatments that are happening at that time. So that's all going to make a difference as well. So these are all some of the things you're thinking about and the differentials. And the last thing that Imran said that I'm not sure you all caught is that Pheno and the idea of eosinophilic bronchitis. So there's a condition that most of us in primary care are not terribly familiar with called non-asthmatic eosinophilic bronchitis. So it's eosinophilic inflammation in the lungs, but it doesn't cause asthma and changes on the spirometry and the lung function. So it could certainly be a case like that. And you have to really get to that to figure out whether or not there's eosinophilic inflammation or not. There's her situation, if her Pheno was low and her eosinophil count's low, then probably that's not the case. Otherwise, it's quite a difficult diagnosis to make, and we can't really make it in primary care. And Imran, maybe you just want to jump in here and talk about what you would do and how you consider someone with NEB and when you'd investigate and what tests you do.
Yeah, so as you mentioned, Alan, non-asthmatic eosinophilic bronchitis was first described by Freddie Hargreaves and Peter Gibson in the late 1980s. And the classical definition is that you have to have a sputum eosinophil count of more than 3%. Some people use a 2% cutoff, but 2 to 3%. And usually it's responsive to oral prednisone or high dose ICS, inhaled steroids. But some people are still not responsive despite being on those as well. But unfortunately, many family physicians may not have access to that kind of population. So if you haven't got access to that, if the blood eosinophil is, as Alan mentioned, is like 300 or more, then that's a sign or a hint that it could be, especially if there's methacholine negative. So you might just want to give them a burst of oral prednisone for 2 weeks and inhale steroids and say, well, if your cough completely goes away or dramatically improves, then pragmatic definition is, oh yeah, it probably is eosinophilic bronchitis, probably is. But that's the caveat that you haven't had objective tests. But if you're out in a place where it's not available, I think that's a reasonable thing to do based on the blood eosinophil count.
The diagnosis is often proven by bronchoscopy and biopsy. So that's sometimes the step. So you're going to have to refer. That's why I say we can't really make it in primary care unless you're willing to give people a big blast of oral steroids for a couple of weeks and try that. Or you have to make a decision, or should they be referred on for a proper bronchoscopy and biopsy first, because this is a long-term illness. We have to solve layers. So it's probably better to try to make a diagnosis more fully. But if you're desperate and don't have ability to get somebody in, maybe they had a pandemic and the waiting list is too long, then you could try something like prednisone. All right. So back to you, Sara, if your cough.
If I quit coughing? Okay. So basically, I don't wheeze unless I get into a coughing attack. I do exercise typically 5 days a week, either doing 3 to 5 kilometers, running or biking. So cardio wise, I don't wheeze. I also do strength training. I don't wheeze. No hospitalizations. Basically, I don't wake up anymore at night because of my Lyrica. That does seem to help. But your cough.
So what you're seeing, Sara, is the frustrations of people with chronic cough. I mean, you can bring it, you can hold it back for so long, but eventually you just can't. The cortex is an organ in our brain, and we can suppress some of our cough. But as Imran will tell us later, it's a disease process in itself, and he'll show us that you can't always stop it. And you can see the tickle that she had and the fact that she's coughing now. And as much as she wants to be talking to you, this is affecting her life, and she can't. And she's being treated now, right? So we'll talk about some new treatments that she's looking forward to getting on down the road. But that's just I just want to point out the fact that hey, this is what patients with chronic cough suffer with. So back to you, Sara.
Thank you. So it is, as Dr. Kaplan said, it does affect my daily life because we do a lot of teaching in home care. And this is what happens is I can get into a coughing fit, and especially with COVID right now, people look at you like you're, oh my God, contagious. So it's one of those things I deal with every single day. And that's fine. You can go to the next slide.
So along those lines, then, what would you suggest? So Imran's already given you an idea about using a prednisone trial. And Imran, why don't you just get into a little bit about what the dose is and how long you treat for?
Yeah, so again, there's no kind of evidence base behind this, but generally I would normally give 30 to 50 milligrams of prednisone for a 1 to 2 week trial. And if the cough dramatically improves, then I know that, okay, there's probably some uncontrolled eosinophilic inflammation in the lungs. I think I would only add Ventolin in people who I know, I mean, generally, I can't remember for the last 2 years ever prescribing Ventolin for people with asthma, because now the GINA guidelines suggest that, it should be, even the reliever therapy should be an ICS LABA. And the concept is that you're kind of adding in you're treating the inflammation as well as the bronchodilator component, because as you know, the Ventolin is not it's not an anti-inflammatory, but it's a bronchodilator. And overuse of salbutamol has actually been associated with worsening asthma mortality. In fact, in England, the National Review of Asthma Deaths has shown that the use of 2 to 3 inhalers per week, puffs per week, is associated with increased deaths and actually increased bronchial hyperresponsiveness and worsening inflammation. So I wouldn't generally add in Ventolin. If I think that there is definite asthma, then for sure, option C and D are decent options. Although for the latest GINA guidelines, the preferred option is to use an ICS LABA as PRN or as maintenance plus PRN as smart therapy. The issue about PPI, which we'll come to again, is that the evidence suggests that anti-acid therapy, because PPI is not an anti-reflux medication, it's an anti-acid medication. It neutralizes the acidity. It doesn't actually stop the refluxate coming up. So I only tend to give people PPI therapy for 2 months if they have strong evidence of heartburn, indigestion, belching, or feeling something coming up. And I give them a trial for 2 months. I often add in famotidine, or in the old days, ranitidine, or sometimes even domperidone or metoclopramide, if I think there's a motility issue. If the patient tells me that food is getting stuck, I'm finding it difficulty swallowing, I sometimes do some studies to look at that, esophageal motility or dysmotility, and sometimes give prokinetics for that reason. And that was also discussed in the last ERS guidelines, that not to give PPI empirically to everybody, because the response rate is very, very low.
You want to rule out other things, hopefully, first. So what you're hearing us say here consistently is we need to try to make a diagnosis before we just throw the kitchen sink at people. And I think that we tend to throw kitchen sinks at people, don't we? Because the patients are desperate, they're complaining in front of us, we have to do something. But sometimes the right thing is not to do anything other to try to make the right diagnosis that's there. Now, after that patient lose weight, Sara does not need to lose weight. It's bad enough she can't eat vanilla. Hopefully she can eat chocolate, and that won't be so bad to lose any weight. And Pam asked a question about how expensive a Pheno detector is. We're from a pulmonary function lab. So just to tell you, I mean, it is about $1,500 or so for the machine and a number of tests. You have to buy a certain number of tests. The only one that's available in Canada is through Aerocrine, and the tests do expire within a year. So it is a bit of an issue. You have to sort of know how many you're going to use because you don't want them to expire after you paid for them. But they are available. The company is called Aerocrine, A-E-R-O-C-R-I-N-E, or the machine is called the NIOX meter. That's the one that's certainly available in Canada right now. So as we move along, back to what happened to Sara. So she said she had a normal FEV1. She's had trials of asthma therapy. It didn't do anything. We've already talked about SABA. Monotherapy in asthma is not a good idea based on the GINA guidelines. And even our recent CTS guidelines have said the only time you'd give someone a SABA alone is someone who basically only uses 1 SABA a year, is perfectly controlled, has never had an exacerbation, doesn't smoke. I mean, it's just a very small segment. So there's a little bit difference in CTS and GINA, but the overall idea here is to treat the eosinophilic inflammation with an inhaled steroid. So it could be an ICS LABA, as Imran had said, or you could give a SABA. Every time you give a SABA, you could give a dose of an ICS. These are other methodologies as well. But the point here is don't use SABA monotherapy. But the other point here for cough is it doesn't work. So you can prescribe all the SABA you want, but it's not going to solve the problem. So you're really just treating yourself, maybe getting the patient out of your office for a little while. But again, we want to make the right diagnosis. We've talked about prednisone, we've talked about PPI already, so I'll move past that. Okay. Back to you, Sara.
Okay, so we did, just to back there, I was on Advair for quite some time before my first spirometry with my respirologist. They then put me on a trial of Asthmanex. Again, same thing. The LABA didn't really, sorry, not the LABA, the ICS didn't really do anything per se. Funny enough, if I do get a chronic infection, I do wind up usually on a prednisone short term, and it usually does help with the cough. Funny enough, we did try the Singular, and Singular did not seem to make a big difference. And I have cough syrup. The only real cough syrup that makes a difference for me is a codeine-based cough syrup. But a little caveat to that is that I am allergic to codeine. So I can't take very big doses of it. I take about 1/4 of a teaspoon when I take it, just enough to kind of ward off the cough.
Sarah, I
So
had a quick question. You know the Advair that you were given, was it a powder or was it a puffer?
it was a puffer.
Because many of my patients, they can't tolerate the dry powder because that dry powder
That's right.
actually evokes the coughing.
Any any dry powder makes me cough.
Yeah.
Like I know everybody loves the Elliptus. I can't go near an Ellipta. They make me cough.
And that's an
Well, that's
important sign
good
of
because you don't.
hypersensitivity.
Pardon me?
That's an important
good.
sign of a vagal hypersensitivity that we'll come to in a second.
Yes. Yeah. Yeah, that's one of the things that's always been an issue with me. If I use an MDI, I'm typically fine. But if I use a dry powder inhaler, I'm in trouble. Yeah.
Well, fortunately, you guys with them because they don't work and you don't have asthma. So that's just great.
Absolutely, right? Yeah. So I don't take those anymore. I haven't taken those for years now. But the cough then continues to, as you saw a little bit of it, this is nothing compared to what I normally get. So it gets to the point where I cough, 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 to the point that I have major rib pitch. I should have like a 6-pack and I don't. But from all that coughing, I am really working those muscles. I tend to avoid going into quiet places. Church is interesting, especially with our mask. It makes me cough typically. And as far as doing speaking, I do a lot of teaching of CPR, a lot of presentations to our patients as well as our peers. And again, it's very hard. And most of them know me now and know me well enough. And I usually start my presentation by saying, if I start to cough, just give me 5 minutes, I'll be back, take a break. And it'll be, I've come to work around it because I didn't have a choice. So yes, do I want to see a different improvement? Absolutely. Was there anything out there? Not particularly. So we're getting there.
And sleep and the effect on the quality of life, if it's interrupting your sleep and waking up, you can't underestimate how worse.
Absolutely.
So, Imran, why don't you break the slide a little bit? I think we've talked about a lot of this already. Maybe we'll leave the bottom right corner for now and come back to that a little bit later in terms of the treatment for RCC, UCC. We'll talk about the others.
So one of the things that I often do is I often think of chronic cough and try to think about what are the components which are really driving this coughing. So I tend to, particularly in asthmatics or people who are presumed asthma, that, does this patient have eosinophils in the airways? If they do, then I'm thinking of inhaled steroids, prednisone. Unfortunately, at the moment, we don't have any evidence that any of the newer biologics has any effect whatsoever on cough. We're actually doing a study on mepolizumab to try and see whether or not in people with refractory chronic cough with eosinophilic airways disease, that mepolizumab, does it improve coughing? So, but the evidence is not there yet. On the top left is the smooth muscle component, the twitchy airways. And if there is evidence in the spirometry, or if I do repeated FEV1s and I'm noticing the FEV1 is going up and down, and there's some twitchiness on the methacholine, then I'd be thinking of an ICS-LABA for sure. The evidence for a leukotriene receptor antagonist, which I'll come to next, is very weak, based on only 3 studies. And this evidence for LAMA, which is the anticholinergic component, again, there's only 1 study of aclidinium, and that was done in COPD patients. And that suggested a very small symptom improvement, which did not meet the minimal clinically important difference. So then what about the mucus, which is the bottom left-hand corner? And unfortunately, we'll come to this in a second. The evidence is very, very mixed. Just today, before I came to this talk, there was a paper published in the Annals of ATS looking at azithromycin in chronic cough with interstitial lung disease, and there was no improvement in the quality of life measures. And the final component, which I think, again, which we will come to again, is this neuronal hypersensitivity. And I'm often thinking that out of these 4 quadrants, which one is the predominant thing going on? And then I will try to target that, which I think is the predominant thing going on. Next slide. So next. So this next, and again. So this is the most recent review done by the ACCP, American College of Chest Physicians, looking at chronic cough due to asthma and non-asthmatic eosinophilic bronchitis. And the bottom line of this large review was that cough-specific studies in asthma are limited, as this symptom is not captured independently of other symptoms in most studies of asthma. So some of you will be aware of the ACQ, the Asthma Control Questionnaire. It has shortness of breath, wheeze, and chest tightness, but no question on cough. So we are really limited in the amount of data we have on cough. But what they recommend, which is again, low quality evidence, conditional recommendation, is that if you think they have asthma or cough variant asthma, then try an RCS-LABA. And if you think that doesn't help, then you may want to consider adding a leukotriene receptor antagonist, but that's only based on 3 studies. The study on the left was done by Peter Dispengatis, who showed that when you give people Zafir-Lucas, there is a significant reduction in the cough scores compared to placebo. But again, this is not a validated endpoint. And he also showed that you get a reduction in the capsaicin cough responses. This study by Spector et al. Was done in 2004, which showed that there was an improvement in those people who had Montelukast in their change from baseline cough scores. Next slide. And this last study by Keeter et al. Showed no improvement with compared to placebo. So the studies around leukotriene receptor antagonists are really, really, heterogeneous and doesn't give you a clear answer. But sometimes I would use it if I've run out of all options. Next slide.
And clinically, our thought process for that would often be the rhinitis component. So when there's combination rhinitis and asthma, it's not an unreasonable thought to try that.
Next slide. Yeah, go for it.
So sorry. So I did try, as we said, the montelukast, and I did not significantly find there was an improvement in my cough. I was then sent to another respirologist at a cough clinic at the Firestone Clinic, and he did a lot more information with me. He did more blood work. We did a sputum induction. We did another spirometry. I think he even did his own methacholine study. And basically the final diagnosis for me was a neuropathic cough with an increase in epithelial cells in the sputum. So
that's, every family doctor can diagnose like that. That's really easy. So understand that this is complicated, and you're often going to have to send people to a variety of people. Part of our job as primary care docs is going to be coordinating that, making sure the person doesn't get lost. Often spending to more than one specialist at the same time, which is not usually how we do things, but you have to rule out one thing, you have to rule out the other thing so we can get people onto the proper treatment.
absolutely.
So with all this, we say, okay, you got asthma, treat the asthma. If it doesn't work, it's not the asthma. First step, of course, is to make a diagnosis proper of asthma. And you heard Sara say that she never actually had spirometry done in all those years. It wasn't because she was born before the advent of spirometry, it's because nobody ever actually did it. So we have to think about that. And we know from studies like Sean Aaron's work that showed, a bunch of people who were taken out of the community who were told to have asthma, and they went back and a good third of them didn't have asthma at all. And some of them had other bad conditions. But the number one predictor of them not having asthma was never having a proper diagnostic test. I know it's hard to get spirometry now. I know COVID makes it complicated, but remember, we do have to make firm diagnoses. Cough variant asthma, we use that word all the time. I don't really like it very much because I don't think it's very specific. But again, yes, we see people who cough and do respond to asthma medication. So, but again, if their spirometry tells you got asthma, then that's fine. Otherwise, they don't have cough variant asthma. Again, a firm diagnosis is everything we want to make here. Please, we need to make a diagnosis because it can save people many years. If you made a diagnosis of asthma and you're given treatment and it didn't work, then you got to do something else. If you made a diagnosis of GERD and you gave a couple months trial of PPI and it didn't work, you got to go on to something else. You can't lose these people down that endless loop of recurrent time waiting, and the patient saying, well, you didn't call me back, so I guess it's not a big deal. It is a big deal for them. And we're going to get into trials of therapy and so on for different conditions. It all makes sense. That's our life. We try therapies all the time, but we still have to have the eye on the prize at the end of the day saying, wait a minute, is this person getting better? And what am I actually diagnosed here? So we do have some new terms for you, and there's two terms. One is called refractory chronic cough, and the other is unexplained chronic cough, called RCC and UCC. And quickly, RCC is there's a disease, a diagnosis made. In Sara, it was made erroneously, perhaps, of asthma, but still the treatment hasn't fixed the cough. Unexplained chronic cough means with all this, we've made no diagnosis. We've done all these different tests. We'll talk about a few more of them, and we do not have a diagnosis to explain that cough. The bottom line is they're really not all that different because they end up sharing similar pathways that Imran's going to talk about at the end. Okay, it's a little more common in women than men. It's more common in people in their 50s. Sara was a young baby for this to start. It's not the case for her. Triggers, are all kinds of things that, understandably could irritate, but don't make most people cough. and they're coughing, again, hundreds of times a day for many years. It's staggering when you actually think about it. Okay, we have this terminology of cough hypersensitivity syndrome. I'm going to come back to that term in a little bit. And again, there's treatments now that we're looking for that. So what do you do now for this person, right? So further trials on spec we've talked about. Should she have a PPI? She's already had a PPI. She told you that story. But if you're developing this case linearly, would you try a PPI on spec? And it's quite true that not everybody who's got GERD will have GERD symptoms. So they can have silent GERD and still have cough. And I've seen a number of people like that already. So it does happen. If you want to go back and do something more like a gastroscopy or an acid test, we'll talk about. Sara, if you remember, had a 2 of 6 systolic murmur. So should we want to do an echo? And then, of course, you can think, what's your next referral? Like, you got all these choices. Which one is next? Is ENT to look at the nose and the upper throat? You want to look at GI to look at the stomach? You need a cardiologist because of that murmur. So what are you going to do next? I'll take some of the guesswork out of you by saying, here's her echo. And her echo did show some thickening of the aortic valve and a little bit of mitral regurg, tricuspid regurg. Probably one of those was responsible for a bit of a murmur she had. Bottom line is nothing terribly important. She was not in heart failure. She did not have systolic dysfunction or even diastolic dysfunction to explain this, although she is on a diuretic, but of course, if that was going to work, it would have worked already. So she's not on an ACE inhibitor, which is another important thing to think of cough, so please don't miss that. There's certain drugs that can cause cough, ACE inhibitors, sitagliptins, a diabetes medication that can cause it as well. You know, there's a few other things that can cause that. So you're thinking about that differential the whole time through. So our next referral was to a GI specialist, and I think that's very appropriate. Now, no one's ever looked at her larynx directly, so the GI doctor will look at it on the way down to the stomach. So they're going to have a look. So you get a free ENT consult if your GI doctor knows what to look for, and we can't always assume that, unfortunately. So you want to make sure that they understand this is for chronic cough. They're usually going to look. And by the corollary, you'll get a lot of ENT docs who see people with a cough and they say, well, we think it's reflux because the cords are a little bit swollen, which they blame on acid. So that's not an unusual thing. All right. So she had a little bit of GERD, let's say. Let's say there was a little bit of esophagitis in her case. You know, what do you want to do next for this person, or what do you want to do on spec for a person? Imran, you've already sort of spoken to this already. Your choice of PPIs and H2 blockers. But what do the guidelines say?
So the guidelines say that to only use H2 blockers and PPIs in those people who have ideally objective evidence of reflux. Now, it's very difficult to get objective evidence, even in McMaster. You know, to do a 24-hour pH impedance study with manometry, there's often a 4-month wait. But you may want to do an OGD, a gastroscopy, and have a look structurally and just look that is there evidence of inflammation at the bottom of the esophagus, it's a hiatus hernia. Sometimes that can give you an indication. And if that is the case, then you may want to, and they've got symptoms of heartburn, indigestion, bloating, belching, cough which is worse on lying down. That's a good often sign. Cough which is worse after eating, approximately 10 minutes afterwards. And cough which is worse on lying down. That sometimes gives me an indication that this could be reflux, and I would try those on those things. The other thing I would mention about Nissen's fundoplication, there's never been a randomized controlled trial. However, Chris Allen, who used to work here at McMaster many years ago, is now retired. He did just a retrospective review of people who had chronic cough and were given PPI therapy, medical therapy, versus Nissen's fundoplication. And there was no difference between medical therapy or Nissen's fundoplication. I only refer for Nissen's fundoplication in those people who have terrible reflux with cough, and they actually need the Nissen's fundoplication for the reflux anyway. So then you're treating the reflux, and as a bonus, hopefully you might think the cough might improve. You've got to be slightly careful with the fundoplication, because you want to do a manometry before you do that, because if you tighten the sphincter and you've got esophageal dysmotility, when you're eating, you don't want to make it so difficult for food to get down because you've tightened the sphincter. So you've got to make sure that they haven't got dysmotility or weakness in peristalsis before you do the Nissen's fundoplications. And that's why a GI specialist referral is very important, because they would do that before they even consider Nissen's. And perhaps, Alan, you might want to talk about the lifestyle modification, which is important as well.
Well, listen, it is important as part of it, but I think a lot of people recommend doing that only as the treatment. My problem with that is it just takes too long to make a big difference. But simple things, decreasing pressure when you're not eating right before you go to bed, elevating the head of the bed on a couple of boards or something like that can all make a big difference for that. And of course, what you eat makes a difference. spicy stuff can make a bit of a difference to that as well. So, that's what the recommendation often is, these conservative things first. I've got that in a slide, it's in writing. I can tell you that myself, I never do it first, I do it in addition, because I think if I want to make a diagnosis, I want to treat, and I want the person to get better, I can always back off the treatment once it's successful to lifestyle modifications if it's worked. But again, Sarah's been suffering for years and years and years. She does not want to be told to lose weight when she's more fit than I am. It's just not going to be the answer that's going to be there. But elevating the head of the bed is pretty reasonable thing to do. It's easy. You can't just use a pillow because that just gives you a sore neck. You've actually got to elevate the entire bed or get a bed that bends a little bit, but even that can put pressure on the abdomen, so it's not good. So I tell people to put a good solid, couple pieces of wood, not just a brick or something under there. And a couple of reasons. Number one, because you want it to be nice and stable. The last thing you want to do is to fall off the bricks or the things in the middle of the night or during other activities. So be careful of that. All right, so with all this, this cough can be related to GERD. It's a fairly common cause of GERD. I mean, if we look at the commonest causes of chronic cough with a normal X-ray, the big three are going to be the nose, the lung in terms of asthma, and GERD. And that's going to be the big three. So if you have to think about what you're going to trial therapy of, those are going to be big three. Well, Sara had all those things treated, and she still wasn't better, which should have been a big highlight to say, hey, that's not what it is, right? So it took, a colleague to sort of say, Sara, that's not normal, when she'd already just adjusted to her life being that way, and it was good what's going to be. So I think that we recognize that it's not always a respiratory problem that causes cough. It can be other things as well, and we're going to talk a little bit about that in the next little while. So here's a summary of what Sara's already shared with us. She's seen a bunch of different people, a bunch of specialists, and they've come to this condition that, maybe it was a refractory chronic cough because she had asthma and GERD, but actually probably not. So I think at this point we call it unexplained chronic cough, although she does have a little bit of globin deficiency, which might actually precipitate more of those chest infections she had. And we have this name for it, we call it hypersensitivity cough syndrome, where her lungs, upper airway are more sensitive to stimuli. And Imran's going to talk a whole lot about that. And the analogy I want to give you about this, and call this neuropathic cough, as Sara described, the analogy, as all of you work with in practice, is people with neuropathic pain. And you know that the continued stimulation of pain receptors leads to proximal changes in the nervous system and leads to neuroplasticity and changes. The same thing happens in the lungs. There's neuroplasticity in the lungs to the nerves that control the lungs, and that's going to cause that continued cough. So when you think about this, think about the analogy to neuropathic pain and neuropathic cough, and amazingly, there's actually an increased incidence of chronic cough, and Imran taught me this, in patients with chronic pain. And I'm a chronic pain doctor, and I didn't know that. So thank you, Imran. He always teaches me something every time I talk to him. So just understand this. This is a neuropathic issue, right? So we have to think about it that way. And for that reason, she was given Lyrica. The cough syrup is a whole other conversation that we won't get into now. There are other narcotic cough syrups other than codeine, Sara, but I hesitate to say that because narcotic cough syrups are a lousy treatment, as you well know. So, Imran, you want to just talk about?
Yeah, I mentioned this before about if somebody has evidence of bronchial inflammation, because we all are now used to giving azithromycin in people with bronchiectasis, non-CF bronchiectasis, to reduce exacerbations. There's also the AMAZES study for asthma, for people to. So when we studied this in the ERS cough guideline, we identified 3 studies which looked at azithromycin in chronic cough. And the studies which actually, the only study which really showed improvement was the study in which there was evidence in patients with chronic cough and COPD and chronic bronchitis. So where there is evidence of neutrophilic inflammation, then in that population, azithromycin may be of benefit. And that's the reason at the end, in the ERS task force, we said that there's insufficient evidence to give azithromycin to everybody, but in people who have chronic bronchitis and mucus phenotype, it may be of benefit. 250 milligrams, Monday, Wednesday, and Friday for a 3-month trial. And that's why you see in this studies, there's heterogeneity. In one study, it was good. In the other studies, it didn't. So yeah, next slide.
So azithromycin is being used for recurrent exacerbations of both asthma and COPD in the right people. 3 times a week is enough, not every day. In some of the COPD exacerbation trials, there's significant evidence of hearing damage, as much as 18% of the patients. So 3 times a week is enough. Don't give any more than that for this treatment. And it's not just about the infection, although I put persistent bacterial bronchitis up there, it's about actually treating the inflammation, the neutrophilic inflammation. Lastly, in children, there is a condition now being described as persistent bacterial bronchitis. So when you see those kids that continue to have a wet cough, you do a chest x-ray and it's normal, and we're reluctant to give antibiotics without a good diagnosis, but there is a group of these children that actually have this persistent bronchitis, and antibiotics are the right thing to do. So think about that. And Imran, there was a question from Daniel about, can a history of pertussis or RSV create ongoing inflammatory changes and symptoms?
So that's a good question. So pertussis is known as a 100-day cough, where they have this cough for about 100 days and then it kind of weans off. For RSV, sure, RSV is very common in children, and approximately 40 to 50% of patients that I see, they'll always say, well, it started off like a cold-like illness, and I was expecting it to get better, and it just didn't. So there's some epidemiological evidence to suggest that rhinovirus, and even RSV and rhinovirus, can both cause hypersensitivity of the cough reflex, such that it then carries on for a long time afterwards.
So we did, both Imran and I have separately and together created some algorithms for this in both primary and secondary care. I'm going to show the one that we created first. It's available on the Family Physician Area Super Canada website. So in terms of people coming to us, they've had cough for 8 weeks. We think about things. We talked about smoking. We talked about ACE inhibitors, sitagliptin. We talked about exposures. Examine them, get a chest x-ray. The red flags are listed here, and they make sense if you sort of think through them. Are they coughing up blood? Smokers with new cough, you're thinking about cancers. And of course, cancers can not just be a big change, it can be something endobronchial. So sometimes you have to keep pushing for things like that as well. Dyspnea along with the cough is not just the cough. Something's causing to be short of breath as well. Hoarseness, something's involving the vocal cords, being the vocal cords themselves, or a tumor involving the recurrent laryngeal nerve causing paralysis of the nerve. There's all kinds of things that can happen there. Systemic symptoms, you're thinking about infection, thinking about, depending on where people are from, things like tuberculosis and non-tuberculous mycobacteria. Swallowing issues, again, there's a mechanical or a neurologic problem. Vomiting recurrently, recurrent pneumonia. We've already heard Sarah's had a mild immunoglobulin deficiency, but it could be worse than that. And of course, if someone has an abnormal chest exam or an x-ray, then that's no longer just a neuropathic cough. That's a problem. So as you do that, you're going to think about asthma and GERD. We talked about that already. You're going to think about other causes. We talked about those common ones, and you've been introduced to non-asthmatic eosinophilic bronchitis as something to now worry about, because it's not something we can often diagnose. And while you're waiting, we want to make sure that people are being seen by the right people. But I really wanted to highlight the bottom thing there. Continue to support your patient through their journey, because they're having a rough journey. And it's amazing how just a few simple words can end up making somebody feel different. We're going to figure this out together. I'm with you in the long run. And that's, if Sara had someone like that to actually continue to go back to reinforce that, then hopefully it wouldn't have taken so many years. And we talked about all these different tests that we've already included. We've talked about most of them already. We talked about endoscopic and examination. We talked about pH testing, and not a fun thing to stick a probe down your nose and leave it there for a day, but you got to do these things. CT scans, echoes, and bronchoscopies we talked about. So Imran, this is the one that we put in an article together that Imran was first author on. And I'll do the primary care one, you'll do the secondary care. So very similar. Think about, make a diagnosis of how long the cough is, what triggers they are. Some of the questions like what triggers the cough is important. Think about other symptoms that could be related to that. We've talked about ACE inhibitors and smoking, chest X-ray with reversibility or a challenge test, X-ray and a blood count, and of course the red flags are there. And again, there's just some ideas here at the treatments for the different conditions. We're not going to get into that. We don't really have time for that. We've already mentioned a lot of those things. Just highlighting, of course, that LAMA should be part of the management of the COPD. But if it persists, actually, I guess it's no longer under review, Imran. We should change that.
Yeah.
It's been accepted.
It's available with open access. It's easily available on the Canadian Journal of Respiratory Critical Care Medicine. As in secondary care, we've split it to say that our job in secondary care is to confirm any diagnoses. And often we don't do all of these tests. We look at the history, we take the history, and we think, what do I really think is going on? Often I'm doing a spirometry, reversibility, and challenge. I will sometimes do sputum. Sometimes I'll request pH impedance and manometry, but not all the time, maybe in about 10%. And only if I'm concerned, I will do nasoendoscopy and CT sinuses. And if there's evidence of choking or difficulty with breathing or sudden loss of voice, then that makes me wonder whether they have something called inducible laryngeal obstruction or muscle tension dysphonia. And a laryngoscopy in that situation can be quite helpful, and it can help further on with speech therapy. Somebody's asked a question, what is BEC? BEC is blood eosinophil count, Joseph. In clinic, I often ask for cough severity on a numerical scale or a VAS scale, and we do quality of life tools, just the Leicester Cough Questionnaire or the cough and the cough quality of life questionnaire developed by Richard Irwin. And then based on what I find, I treat. If the cough persists, if there's an underlying condition, I'll say it's refractory chronic cough. If there's no condition that I can find, I'll say it's unexplained chronic cough. And then depending on what's available, I will either try speech pathology or neuromodulatory treatment. And these are the ones that we have. Pregabalin, gabapentin, low-dose morphine for 2 weeks, or amitriptyline. I will then assess the benefit. If there is benefit, monitor the side effects and titrate the dose. If there's no benefit, then try something else, one of these neuromodulators, or recruitment into clinical trials, which we at McMaster do quite a lot of. Next slide. So these are the treatment options for if somebody has neural hypersensitivity or cough hypersensitivity syndrome. Speech therapy, it's good because there's no medication involved. The bad side is that you can't just send it to any speech therapist. You need to have a speech therapist who's really interested in chronic cough, because then they can give you very specific treatment plans. So access is difficult. Often they have to pay for it out of pocket. And there's only one study showing improvement in cough frequency reduction. And it was only done for a short period of time. So the other treatment that I try is low doses of morphine. These are very low doses, 5 to 10 milligrams, modified release, or sometimes extended release. There's one study which has shown improvement in randomized controlled trial. But the reality is that opioids has been used for cough. I found manuscripts going back to the 16th century showing improvements with opioids. So although there's one randomized controlled trial, people have been using this for years, centuries. So the newer medication like pregabalin and gabapentin, they are also centrally acting, and they inhibit the presynaptic voltage-gated calcium channels. And again, there's one study each for each of those, but you just have to be very careful about side effects like drowsiness, hallucinations, and dry mouth and nausea and sleepiness. Although the clinical trials use 150 milligrams BID for pregabalin and 300 TID for gabapentin, I have never, ever been able to get up to those doses. For pregabalin, often I use 50 to 100 milligrams and then see how it goes. For gabapentin, I normally start at 100 milligrams TID and then maybe 200 and stop there. Amitriptyline, there's only one uncontrolled study, which is not placebo-controlled, 10 to 25 milligrams once a day. I often use that in people who have concomitant depression and anxiety. Sometimes it just helps them in that patient population. So these are the current treatment options. Please note, these are not licensed. These are not licensed indications for chronic cough. We do not have any licensed treatment for chronic cough. These are just based on guideline recommendations. Next.
So these are all drugs we're all familiar with treating neuropathic pain. You start low is the key thing, because do is over sedate people with it. So I'm just going to spend just a couple minutes. I know we're a couple minutes over now, but if you just sort of bear with us while we talk about the mechanisms of chronic cough.
So next slide. So just to give you an understanding, cough is a defensive reflex, and the way it's initiated is you have this vagus nerve, which is the 10th vagus nerve, which sends sensory signals from the afferents, which go to the airways. And there's two types. There's the jugular C fibers and the nodose A delta fibers. And when you stimulate the airways, next, let's go press next. Action potentials are generated. Next. That goes to the brainstem and the higher somatosensory cortex. Initially, you might get a throat irritation. Everybody does. Then next. And if the stimulus is great enough, you might get an urge to cough. And then eventually, next, you might get a cough. Press next. So that's the wiring diagram for cough. Now, the problem is that how does chronic cough fit on all this? So what you've got to understand is that the vagus nerve has also got sensory fibers from the esophagus to the brain. And also, next, from the nose via the trigeminal nerve into the nucleus tractus solitarius. Therefore, it's possible, though, so something in the airways, such as eosinophilic inflammation cells or airway caliber changes or bronchial constriction in asthma, can sensitize those nerve endings. Acidity in the esophagus might sensitize those nerve endings, and inflammation in the nose and rhinitis can also sensitize those nerve endings. And that could all lead to a hypersensitive cough reflex. Next. So I often think of, is the chronic cough because too much stimulation? Next. Or is it because the nerve itself has become exaggerated and hyperexcitable? Or thirdly, is the problem actually in the central nervous system where there's evidence of central sensitization or impaired inhibitory control mechanisms? So next. So I often think of, can I reduce the stimulus? Can I get rid of mucus, eosinophils, any acidity, any environmental or occupational exposures? Can I think of peripheral blockers? Next. So the ones in red are those peripheral blockers which I have investigated in clinical trials and have not worked. The P2X3 is the new one, which has worked, which is coming out hopefully soon. And then these are the central blockers. So the reason why morphine works is because it reduces the sensitivity in the central nervous system. Similar with pregabalin, gabapentin, or amitriptyline and speech therapy. And experimental treatments such as memantine and neurokinin 1 antagonists, unfortunately, haven't really worked in chronic cough. Next. So as I mentioned, ATP can drive airway hyperresponsiveness and sensitivity. Next. And that binds to a channel called P2X3. And compared to healthy volunteers, you'll notice that patients with chronic cough, they are left shifted and upward shifted. They're hypersensitive and hyperresponsive. And next. And the good news is that when you give this new drug, that there's a dramatic reduction in objective cough frequency. And this was the 12-week phase 2 study, 2B study, and the phase 3 studies have now been proved positive as well. Next. The other concept to understand is that there's now evidence to suggest that when you take samples from the biopsies of these patients with chronic cough, you'll notice that compared to people who are healthy controls, that when you stain the nerves, you can see in chronic cough patients that there's more branching of these nerve endings. And what that means is that when you inhale something or when you smells, powders, that you've got more opportunities for these nerves to get stimulated. And that's why I think, Sara, even the smallest of smell, changes in temperature, all of these things are stimulating these nerve endings because the epithelium is degraded because of the coughing, and these nerve endings are just exposed, and you've got more of them. So therefore, you're going to get more stimulation. So the second concept that we've talked about is central sensitization. And here the evidence suggests that what happens, if you go next, is that this is an MRI study. And this is showing that patients with chronic cough, they have increased evidence of blood flow and sensitization in the brainstem. So that suggests a central sensitivity. Next. But the other thing which we noticed in this fMRI study is that there's reduced activity higher up in the brain. And this area in the brain where there's reduced activity is an area of the brain which is used to controlling cough. And these are areas where they send, it's like a brake on the system. So all of us, we are tonically inhibited. Most of the time, our brain is inhibiting things. And we only kind of focus on things which are important. But this area in the brain is very important in inhibition. And in chronic cough, they don't have good activity of this area. And that's why we think, not only, next slide, that not only is there increased sensitivity, that there's actual decreased inhibitory control mechanisms. Next.
And it's a very similar mechanism to fibromyalgia.
Yeah.
Same, you don't have the normal inhibition of pain, so therefore everything hurts, which shouldn't be hurting.
Yeah. Next. So the other important thing is Sara mentioned that when she starts coughing, she can't stop coughing. And one of the ideas, and often people will say, so when somebody says that to you, that I cough to things which I normally shouldn't cough, and when I start coughing, I just can't stop it, that suggests that there's a problem with sensitization, but also lack of inhibitory control. So this is a study that was done to show that people who are healthy controls, when you make them inhale capsaicin and ask them, don't cough, when they inhibit themselves and try not to cough, they're effective. They can reduce their cough sensitivity, as you can see. But on the right-hand side, next slide, but patients with chronic cough, when they ask them, when you inhale this substance that's going to make you cough, try not to cough, they still cough. They can't do it. They can't inhibit themselves voluntarily. So there's an impairment in voluntary cough suppression. Next slide. So this is a complicated study, next slide, where what we try to do is we try to reactivate and understand whether those patients who have got chronic cough, whether they have impaired inhibitory controls, whether the brakes which are supposed to be on have come off. And the best way to explain this is when we're all kids, when we hit our head against the table or something, our mother or father would come and rub our head to try and help with the pain. And it's the same concept that certain things, certain conditioning pain stimulus can actually reduce pain. So we hypothesized whether if you put your hand in cold water by giving you that conditioning pain stimulus, can you actually improve coughing? Can you reduce coughing? So what we showed here on the left-hand side is that just by putting your hand in cold water, next, next. Putting your hand in cold water, not only do you reduce your urge to cough sensations, what happens is that you get a dramatic reduction in the number of coughs. But you'll notice in those red arrows, that reduction is only happening in healthy people. Unfortunately, in the black ones, next slide, next, that reduction is not as good. So what that is telling us is that in healthy people, the brake is working well. The brake is on, it's working well. But in healthy controls, that brake has somehow come off. And interestingly, there's evidence to suggest that morphine actually reactivates that brake. And that's why codeine, tramadol, anything opioid related can help. So this is some new evidence that we've worked on in the last year. We've already talked about this. Next slide. Next slide. Next. Okay, so future treatments I've mentioned. So this is the kind of breaking news that hopefully this is the first time the largest ever cough studies have been done to show that if you block that receptor called P2X3, which ATP binds to, you get a reduction in cough frequency compared to placebo by about 18% in cough 1 and 15% in cough 2 study. These were about 2,000 patients in total. And based on this evidence, this new drug called gefapixant hopefully is currently being reviewed by the FDA and Health Canada. So we're waiting to see hopefully whether or not this will work. But the good news is, apart from this drug, which is owned by Merck, we have 3 other options. There's a new drug called eliapixant, which is going to phase 3, owned by Bayer. There's another drug next called Blue 5937, which is owned by a Canadian company based in Laval, which also is a P2X3 antagonist, which is currently positive in phase 2A and 2B, and they're going into phase 3. And there's another company called Shinogi, which has got a compound called sevoflurane, which is also positive. So now, compared to hundreds of years ago, where we're giving people morphine and pregabalin and gabapentin, which is centrally acting, we're hopefully in the next 5 years going to have 4 different types of P2X3 antagonists: gefapixant, eliapixant, sevoflurane, and I'm not sure what they're going to call Blue 5937. But I'm hopeful that there's going to be lots of new treatments for chronic cough. And this is hopefully a start of a new era for chronic cough treatment. So that's the end. Alan, do you want to wrap it up?
So cough is important. It bothers people. It lasts a long time before we actually figure out what to do with it. Multiple things can cause it, but this neuropathic pathway at the end seems to be the end result of many of these things. You know, we do the job to start off in primary care, but this is a group that needs to be referred to at least rule out other parts of the different differential diagnosis. We've talked about the nervous system. We talked about the analogy to chronic pain, which I think works. We've got new treatments coming, which is exciting. A couple of questions we didn't get to. One, is there any evidence for recommending meditation or yoga in the treatment of neurogenic cough? It's certainly been used as the cognitive cortical issues for chronic pain. Have you had any experience with that with cough, Imran?
So there's one study which we did in Manchester many years ago, which was a mindfulness technique. It wasn't quite yoga, it was mindfulness. where we got people to get kind of in tune of their breathing and trying to control their being present in the moment. And unfortunately, in healthy controls, it works very well that they can cough less. But in fact, in chronic cough, when we did that, we noticed that they actually coughed more. Because what happened was they're just a bit more conscious. They become more conscious of their cough. And in fact, what tends to happen is that they become like more cognizant that, oh, I'm going to cough. Am I going to cough? And interestingly, I have some, on a more different note, I have some patients who are amazing musicians, and they cough a lot, but when they're playing their guitar or harp or piano, they get into their zone and they stop coughing completely. And I'm not sure why that is the case. It could be distraction. But the other thing is that we know that, these descending inhibitory controls that I talked about with the cold water thing, what happens is that the neurotransmitter which does that is endorphins. And we know that endorphins can be secreted when you do anything pleasurable or funny or happy. And there's this idea that maybe we should be thinking about how we can get more endorphins in our body and secrete endorphins. So if playing a musical instrument secretes some endorphins, or doing exercise, going for a run like Sara does, it's possible that most people who cough, maybe Sara might tell that when you're actually running, do you actually cough during the run?
Absolutely not.
See, that's interesting.
I don't cough at all during exercise. Probably about 5 to 10 minutes after exercise, I might have a wee bit of a cough, but typically not with exercise.
So there you go. So this is an interesting thing, that maybe this is endorphin related or even adrenergic related. But these are all hypotheses. I'm not saying I've got the answer to all this, but these are some of the things that people are talking about in the cough world.
The same thing with the yoga, because I have started yoga as well. Okay. And I don't cough during yoga. And those are the nights that my sleep is the best and I have absolutely no cough.
Amazing.
Yeah.
So it sounds like the answer is endorphins. That's good. Listen, it's really exciting to be part of this. It's exciting to meet with this, have this faculty together with us. I hope you've enjoyed it as well. Chronic cough is a new area. It's an old area that's now a new area, mostly because now we have things we can potentially do about it that's different than before. We showed you some organized approaches to how to approach our patient with chronic cough and not have them suffer for as many years as had to. And there was one question about ECGs, Spiro, starting Lyrica, gabapentin, amitriptyline. I think low doses you don't have to. If you start to get high doses, you want to think about it. Remember, azithromycin also has potential to cause QT prolongation. So anything that causes QT prolongation, we should be doing ECGs. So anyhow, with that in mind, just to hope all our questions have been answered. I think they all have. And I want to thank Sara and Imran for really a fascinating time. I want to thank Emily for all the arrangements. I thank all of you for joining. I hope you've learned something. Please don't hesitate to reach out with questions. And Emily, I'll give it to you for last words to coordinate the group.
Thank you, Alan. And thank you again to the three of you for amazing and comprehensive presentation. I think you've done a great job of expressing the difficulties and struggles that patients can face when trying to reach a diagnosis or finding a treatment that works for them, right? So thank you to all of our listeners. Thank you for staying with us a few extra minutes. And thank you again to, of course, to Merck Canada for helping us make this learning opportunity possible. So don't forget to sign up to expandcourses.com. You'll find the recording of this webinar and many other learning opportunities. And as was mentioned at the beginning of the presentation, our chronic cough report is also available online. That'll be in a link and an email tomorrow. So have a great rest of the evening, and thanks again.
It is accredited also, Sara, right? So you will be sending them a certificate for such, right?
Exactly. All right. So if there are any other questions, also remember that you can always email us. I'd be happy to bother Alan, Sara, and Imran to get you the answers.
Are we getting? Is it possible to get like some evaluation or feedback from the participants just for our benefit?
It'll be sent immediately after once I end the webinar.
And what they liked or disliked.
Exactly. Yeah.
So please do evaluate. Imran really cares. All right, come on. All right. Good night. Thank you so much for joining us. As Emily said, we will be taping either this one and the one next week. We'll have one of those up on the line if you want to watch it again. Don't hesitate to reach out if you have questions. We're more than happy to answer you. Stay safe, everyone. Have a good rest of the night. And thanks again to Sarah, Imran, and Emily for making this all happen. Good
Thank
night,
you,
everybody.
It was
Thank
great
you.
sharing the
Thank
platform
you.
for all of you, Sarah, Alan, and Emily.
All right. Have a good
Thanks.
evening.